So this patient is going to have cataract and implant surgery done. She also will need to do some penetrating limbo-relaxing incisions at 140 degrees. More about that in a moment. So I'm going to take the toric axis marker, and you can see the 90-degree mark. That'll align with the 6 o'clock mark. The handle aligns with the 12 o'clock mark, and simple depression gives me marks at 140 degrees. Now, clearly she doesn't dilate very well, and that is probably a consequence of the calcium channel blockers that she takes for hypertension. In this case, amlodipine. Okay, so if I'm going to make limbo-relaxing incisions here, I don't want to make my side port incision there, obviously, right? I want to put it somewhere else. So I'll just move down to here and make my side port incision there. Now I'll move my temporal clear corneal incision very slightly in that direction, but not so much. And that's a 2.4 keratome. Right up to that line is a 2 millimeter tunnel. Depress, enter. And if you want to get in slowly, just wiggle. If you have a deep chamber as you do here, you can just go straight in like that. Now the next step is intraocular lidocaine. So you might feel a little sting for a few seconds. For those of you who aren't familiar with that sting from lidocaine, it feels like you got salt water in your eye. That's what patients tell me. Now, will the pupil dilate with either epinephrine, or in most cases that have a bit of a floppy iris, as this probably will be from the amlodipine, the viscode injection will often dilate them. So let's see how much dilation we get from that. Fair amount. Now, some people might be comfortable doing the phaco through that size opening, and some might not. This is not a very dense lens. I would be comfortable doing it through that, but I'll bet it gets bigger after we run a little adrenaline into the eye. So my next step here is going to be to open the anterior capsule, and that's a bent tip 25 gauge needle, and I'm just going to use it to make that opening in the anterior capsule. Now notice the eccentric pupil dilation here, right? You can see it's dilated more here than it is on that side, for whatever reason. So if I centered this capsular rhexis in that pupil, the capsular rhexis would be a bit eccentric. So, what the cornea, please? I will intentionally want to kind of, in my mind's eye, picture the real geometric center of this cornea. And I will want to make this capsular rhexis more peripheral, if you will, in relationship to the pupil on the temporal side, which is toward me. So I'm now headed out a little more peripheral with it. And here we go, a little more peripheral. Now I'll bring it back. So now I actually have a capsular rhexis that's pretty well centered on the visual axis, which is right there, but not centered on the pupil dilation. So next step is going to be hydrodissection. And this is a flat 23 gauge hydrodissection cannula. Notice this elevation. You can see it in this case because I'm elevating the iris. So I watch and I see a fair number of surgeons don't do that little simple maneuver, elevate. That's very important though if you don't want to leave a lot of epinucleus behind. So here we go again, over here, and elevate before you inject. And now you'll see the nucleus come forward a little bit, and that's really what you want to see. Now, whenever the chamber shallows a little, the pupil will get smaller. So I'm not surprised to see that. But after I do the viscodissection here for 180 degrees, I'm now going to redilate the pupil a little bit with a little more visco injection. Okay, the next stop along the way here is to get some epinephrine in the eye. And I'm going to do that via the Phaco handpiece, because we always use epi in the infusion bottle. Now, there are other injections of various chemicals that can be given, In this case, I'm going to rely on the epinephrine in the infusion bottle and see how we go. So first I'm just removing that loose cortex from the anterior chamber so I get a better view. And now the next thing I'm going to do is actually increase the flow rate so I run a little more epi into the eye. So let's go to quadrant removal, and that'll give me 42 cc's a minute. Okay, let's go to sculpt. So for me, that pupil size, if it stays there, is just fine. I mean, I'm comfortable doing the phaco through that. I don't need to do stretching. I don't need to use various dilating devices. Wet the cornea. And now we come to what I consider to be the most important part of phaco in terms of successful nuclear division, and that is sculpting deeply. And you'll notice that I just zoomed in and I'm focusing on that posterior nuclear plate. Because if I can get that nice and smooth down there and get a good red reflex, as I have right in the middle there now, this will chop every time. So here we go. Notice the pupil. It certainly hasn't gotten smaller. If anything, it's gotten a bit larger. So I'll go around and get this thing divided while our pupil is still behaving and behaving better and better as we go along. So I've got this last heminucleus here. Notice, can I see the capsule rhexis margin? No. So people say, well, how do you know you're not on top of the capsule? And the answer is by the way you put in the chopper. If I put the chopper right against the sculpted wall and then hug it as I go up and over, there's no way I'm on top of that capsule. I mean, it just can't happen. But you really have to adhere to that technique every time. Because if you just forget that and just, oh, I'm going to stick it out there, and you go out, boy, you might be on top of the capsule, and I don't have to say anything more about that. Wet the cornea, please, and let's go to quadrant removal.
Quadrant removal.
That was all aspiration. Notice the vacuum level is 600. You can aspirate a lot of nuclear segments with that kind of vacuum level. I'm just lifting up this piece of nucleus there. One of the reasons why I have that ball on the end of this chopper is so I know if I go down and touch the posterior capsule with this, nothing's going to happen. So I'm comfortable going down and reaching underneath a piece of nucleus and bringing it up off the capsule, you know, dividing it that way. That's what I did a moment ago. I do not personally like Sinskey type instruments being used to chop. Always worried about those in contact with the posterior capsule and wet the cornea. So here's our last quadrant. That little circular maneuver there made it come to the tip. Okay, so now we're ready to do INA. And I would say that, you know, the pupil stayed where it was. Maybe it got a little bigger, and near the end of phaco it might get a little smaller. And now we'll need a couple of little tricks from out of our bag, assorted maneuvers, to make sure we get all the cortex out in a smallish pupil. So let's go in with our 90-degree INA tip. Now we can take the low-hanging fruit first, and that would be the cortex that's most obvious. So let's get this part right here. Notice I don't really depress the pedal fully until I get over to here. So now I'm not really using high vacuum anywhere near the capsule. And remember, this is a 0.25 port in this 90-degree INA tip. Subincisional cortex is, in my experience, simple to remove with a 90-degree tip, but so is all the other cortex. Now there's some epinucleus that was hiding underneath the iris there. I'm actually aspirating it. I'm watching to see if it'll actually go in. I didn't need to press it in with the second instrument. Now you say, well, how do you know you got all the cortex? I mean, I'm pretty sure I do. But if you wanted to look around, here's the things you could do. Take the spatula, put it in an iris crypt, push the iris to the periphery. On the side of the spatula, you can sweep. Okay, there's just a little bit of cortex right there. And I'm vacuuming the undersurface of the anterior capsule there. On the opposite side, I either have to use a hook like a Kugelin to push it, or find a crypt and push it. Everything looks good over there. Okay. So we're now ready to implant the IOL, and then after that perform the penetrating limbo-relaxing incision. But first, there's a little PSC opacity. Wet the cornea, please. See that little guy? Not much. I could probably rub it off with a spatula, but there's some other little epithelial cells and fibers there. We'll get those off and show you how I like to do that. So this is now Provisc. Any hyaluronic acid compound is good for IOL insertion. So I'm going to deepen the posterior chamber, focus down so I can see the posterior capsule. And when I'm about halfway down, not all the way down, it'll get out of your microscope focal plane. Then I just rub the posterior capsule as I gently inject the rest of the OVD. Wet the cornea? Good. But I want to emphasize, I'm doing this while I inject. Because if you do it dry with just that needle, you might be able to open the posterior capsule. But I've never opened the posterior capsule while I'm injecting. So this is my sort of posterior capsule scrubbing technique. We're now ready to insert the IOL. Now this patient has a multifocal lens in her other eye from previous surgery. So we're going to inject the identical IOL that she has in the other eye. She's happy with it and has done well with this multifocal. I am not a fan of mixing multifocals. Brands. I don't like to put one company's multifocal in one eye and another company's in another. There is evidence accumulating that using the same brand but with a different ad works okay. Some surgeons are very fond of using a Restore 2.5 in one eye and a 3.0 in the other. And other IOL manufacturers have different power IOLs with the same general multifocal design. And, that may work just fine. But I would caution everyone on using different manufacturers' multifocals in different eyes. It absolutely may work, and certainly has, but in my experience, there's a greater chance of dissatisfaction with one or the other of those lenses. Okay, so the multifocal now is in position in the capsular sac. And I'm going to do the penetrating limbo relaxing incisions. So in my left hand is actually a 2.75 keratome. And I'm going to use that right here. And I'm be in position 1, infusion. So I maintain IOP, and it's just like a Phaco incision. Here we go. Now I'm going to just, still using my left hand to hold this, I'm coming across to the other side. This axis is 140 degrees. I want to be in position 1. Nice rigid globe. Makes it easier to do it. Slowly move it along. Want to enter slowly, wiggle it a little. Those incisions seal immediately and don't require, syringe with BSS, don't require hydration. Unlike the primary incision, through which you've been inserting instruments and kind of taking that linear incision and making it round. And now you got to get back to a linear incision. How do you do that? You just hydrate it. I do not, when I do stromal hydration, I don't go to the very deepest layers. I go to the mid-stromal layer. I want to hydrate on both sides, both deep and superficial stroma, but I don't like to begin it deep. You might someday get Descemet's membrane caught in that, and if you do, you could get a Descemet's membrane detachment. There's just no need to go deep with the cannula. And you see I also hydrated the side port incision. So there's our procedure in a nutshell. I can tell by feeling the globe the IOP is certainly in the normal range, or even slightly elevated, and we're finished.